Talking about chest wall reconstruction today, including the Talon and some work we've done with creating new ribs that we call Neoribs.
Talon is basically an instrument that is responsible for pulling the bones together after they've been separated for cardiac surgery. My dad gave me the idea. He's passed now, but he was a carpenter, a very good carpenter, and he was also in the military. But one of the things he said to me is, if you're having problems with holding stuff together, why don't you just get a C-clamp? And so I kind of parceled something together, and James was walking down the hall, and I said, what do you think about this? He goes, that might work.
Standard way to close the sternum after surgery is with wires, and if you can imagine, that's kind of a one-dimensional closure, and there's still some freedom of movement of the sternum. What the Talon does, it stabilizes in the front, sides, and in the up-down motion, so that it's a rigid fixation instead of a semi-rigid or not rigid. And the advantage of that is there's better healing and less pain. And any of that movement with coughing, breathing can cause pain after surgery.
When you used wire, we would develop looseness of the wire and seroma and fluid gathering, and sometimes even bleeding around the area where the wire was trying to hold the area solid. And the sternum is a very active bone, and it participates in all coughing, all breathing, any kind of upper chest motion, and it is a bone that's constantly in motion. And so any deep breath, any cough, any reaching upward with your arms is going to make this sternum move up and down. Every single rib is articulated with the sternum in some way. These are all mobile joints. Everybody doesn't really realize that that's a mobile thing, that it's actually moving like this. And the clavicle is attached to it, and the clavicle is, of course, attached to the shoulder. So all upper body motions, just about, are connected to the sternum.
The primary advantage for primary closure, meaning first time you have heart surgery, using the Talon as a closure, is decreased risk of poor healing of the sternum, and that's based on decreased motion, more rigid fixation. A side effect of that is the decreased pain, and of course pain is not something that lasts a lifetime, but it's still nice to have less pain early after surgery. Probably 1% to 2% of all patients who've had heart surgery over the past 10 or 12 years, which could represent 20 up to 100,000 people in the U.S. alone, have a sternum that's mobile for a long time after heart surgery, and that causes a lot of pain and a lot of disability. And we've had very good results at repairing those problems with the Talon, and that's those people, speaking of getting hugged,
Yeah.
I mean, they wake up in recovery feeling better than they have in years.
Yep.
And I would just encourage people who may have been told that there's really no option other than to redo the entire operation to contact us. We can put them in touch with people, with surgeons, even local to where they are, that can do the Talon procedure. In patients with infections and cancers of the chest wall where you can't use artificial material, there was really no option. And in fact, that's a fairly common position that surgeons will take now, is that you have no option. And that's simply not the case. We've now done in excess of 20 cases between us where we've resected portions of rib, even in an infected field, used the extracellular matrix material to recreate the lining of the chest cavity, and then to use that to contain the rib graft material, which is a cadaver bone that's been coated with stem cells. And we've demonstrated in multiple patients with follow-up scans that turns into normal rib.
The materials work out very well. The neat thing about it is, I think, that the stem cells themselves, along with the acellular dermal matrix stuff, along with that, I think they work together in synergy and create bone and normal tissues in response to the stuff around them.
A patient with an extensive chest wall tumor that needs a large amount of the chest wall removed and reconstructed, it can, if you remove all of the ribs and don't replace them with something that becomes bone, then that person can have fairly severe disability. Then there are the ones that started the Neorib idea, which are the ones where you simply could not put artificial material, meshes and things like that in the area that was infected and had cancer in it.
Mm-hmm.
So those are the really bad ones. I've spoken with a few surgeons around the country, and these cases don't come up every day in every practice, but there are enough of them that this benefits, albeit a small subset of the population, it benefits them a lot.
Yeah, it actually doesn't necessarily save a life, but it definitely preserves it, and it definitely improves the quality of the people, of their lives, and allows them to interact with their grandkids or with their boyfriends or whatever that they weren't able to do before, and in many instances couldn't because of the pain, infection, constant growth and worsening of their wounds and so on, and dressing changes. These things are eliminated by essentially a trained combination of surgeons like Dr. Spann and myself to reconstruct it in a functional way. I think that the procedure can be actually modified to work with jawbones very easily by stabilization with a plate, and then utilization of the core matrix as a hammock, and then put the stem cells and bone marrow into that. And instead of having to do things like put in fake bone or cadaver bone, you can use this stem cell combination and essentially build a new mandible within 3 or 4 months with that material. And within 6 months to 9 months, I'm pretty sure, you wouldn't even need the plate. The bone would harden up enough so that you'd essentially have a normal mandible again.
The only downside to it is that you might have to do something else to make the chest wall a little more rigid immediately post-op, and we've worked on things like wires put through the middle of it and improve that stability. Although we've done several cases where we didn't have to do anything like that. So there's really no downside to it. I guess it's more of a theoretical downside of not having immediate rigid chest wall, but that has not been a problem, especially with when we replace the sheet of the extracellular matrix to recreate the pleura or the lining of the chest cavity. That gives it enough stability.
Yeah, and I think, when you put the flap over it, either of pectoralis muscle or rectus muscle, when those flaps get over it, they provide extra vascular growth, and they improve the healing quite a bit more.
And they add some to the immediate stability as well.
Yeah.
That's very rewarding.
It's humbling. It really is.
It's just great to see those people that,
Yeah.
especially ones that have been told they don't have any options, and that maybe there wasn't another option, to have an option that gives them back a functional life.
To get hugged by them and to see their smiles. It's amazingly wonderful. It's a great feeling. And just to be part of it makes me feel humble.